We have a series of webinars organized, and today we are fortunate to have a very senior colleague of ours from Turkey, Professor Mehmet Zileli, a dear friend. He has been really the force behind a lot of us. He doesn't let us sleep, make us work a lot all the time. And you know, there are days that he would email me 4 or 5 times about this, many things that I have to do. So you can imagine the amount of dedication that he has. So I'm grateful, and this is the first of these webinars that we're starting on. And on Wednesday, we are going to reverse the role. So Mehmet will be the moderator, and Sandeep is going to be giving a talk on Wednesday. So hopefully we can have that sorted. We'll tell you the time, etc. once this is done. So Mehmet, I think you can start. If Sandeep is not here, we should start, because it's, I know we have 1 more minute to go. Is there anybody has any question? You can type.
Yeah.
Mehmet,
thank you a lot for giving the opportunity. Do you hear me?
Yes, we can hear you very well.
Okay. It's a good opportunity to get online through the internet, because we are all stuck in the homes at homes. Now I am in the hospital, but there is almost nothing to do. We don't accept any elective cases, just emergency care. And we have also very big concerns about the pandemics, COVID pandemics. Most of the beds of the hospital are full with COVID cases. I want to start with my slides. Is it okay? Someone? Okay. I chose this subject because, as Salman has said, this is for the residents mostly. This may be accepted as an elementary lectures on patient evaluation in spinal disorders. First of all, I must stress that patient evaluation is more important than learning surgical techniques. Why do I say that? Because most of the mistakes in spine surgery are being done because of worse patient selection, not because of poor surgical techniques. I will start with this slide. What are the aims of spine surgery? First of all, the decompression is the main aim. The neurosurgeons are very familiar with that. Then the stabilization, which is to prevent pain and neural compression caused by instability of trauma, tumor, and degenerative diseases. Deformity correction is another aim. The surgery for scoliosis and kyphosis, and oncologic surgery to remove the tumors. If you look at the first 3 reasons, in most of the time, it is for pain relief, decompression, stabilization, and deformity correction. Possibly in adolescent scoliosis, it's not. Adolescent scoliosis patients do not have pain at all, but in the adult ages, they mostly have pain because of deformities. If you want to classify spinal disorders, most of them are non-specific. The patients come to you with low back pain, and neck pain. Even they have some MR images with them that is bringing to you. Most of them, they do not have specific diseases, which may comprise 10 to 15% of all spinal disorders. So, because of that, evaluation of pain is very important. pain is the primary and most important symptom, and back and neck pain are the most frequent types of pain in population, probably after headache. And the origins of low back pain are very dispersed. There are many varieties of source of back pain, like disc, muscles, ligaments, and facet joints. So because of that variety of sources of pain, we then have very separate names, terminology, like discogenic pain, myofascial pain, osteogenic pain, facet pain, others. There is no good definition of a single pain type. If you look at the pain physicians, types of pain may be divided into main area. One is the nociceptive pain, which may be divided in axial and radicular pain. Most of the low back and neck pains are axial pain. This is probably 80% of the patient's symptoms. The remaining is the radicular pain. It may be sciatic, brachial, or girdle-like abdominal and chest pain. And neuropathic pain is a central pain, which results mostly because of the injury of the peripheral or central axons of the central nervous system or peripheral nervous system. Then the question arises, do you order MR in all low back pain patients? We must not order in all patients. But if the sources of, why? Because mostly source of axial pain is unpredictable and no tests are necessary. Most of the patients with axial pain do not need a therapy. And if there are red flags, we should then order tests. These are the red flags. Probably most of you know that if there are serious neurologic deficits, if there is a pain intensity which is not decreasing after 4 weeks, if pain does not decrease during rest, during night, it is presence. If new onset pain in a patient with non-previous malignancy, and if there are weight loss, loss of appetite, and the first onset of pain after the age of 60, then you should order tests like MR, CT, biochemistry, bone scanning. So then you may have seen that pain characteristics are very important for diagnosis. And for instance, the morning stiffness is a specific finding with the rheumatologic disorders, but also with discogenic low back pain. Mechanical pain is the pain initiating and exacerbating with activity and without structural signs, like mechanical low back pain, discogenic low back pain, and facet syndromes. If you look at in general, in patient evaluation, the history taking is the must, because we can learn the type of pain the patient is having. Then the observing the patient, physical examination and neurological examination, then the radiology. This is all what we do for patient evaluation. History taking is probably, if you get a good history, you have come to diagnosis in 80% of the cases. You can come without any examination even. Ask the patient characteristics, when, during which activities, period, symptoms, ask all the details. And observe patients during walking. This is a type of examination actually. Look at the patient during walking. You can identify a spastic paraparesis from foot rub. You can identify a Parkinson's disease or a scoliosis or kyphosis. Then the physical examination is very important. Actually, probably our residency programs do not involve it too much, but we must always palpate the painful area with trigger points and sacroiliac joint pain. We must look at them. Let the patient flex and extend the body, and passive movements of the neck and back we must all search for. Sacroiliac joint pain is one very important thing that we are missing many times. I've seen many patients who came to me with a previous suggestion of surgery, for instance, but I examined the patient and found a sacroiliac joint pain only. Some reports say it is 25% of all back pain. Neurologic examination, yes, we must know it, but there is probably too much stress in residency programs, but it is not the sole exam in spinal disorders. We must be also looking at the muscles, the strength, and the flexibility of the body. In an elderly patient with lower extremity symptoms, please search for the upper extremity symptoms. Look at them. For radiology, best test is MR. Yes, CT valuable in bony problems, but the recent trend is standing whole spine radiograms, and then we can measure the sagittal and coronal balance. We must stress that specificity of MR images in degenerative spinal diseases is very low. There is almost no correlation with radiology and degenerative spine disease symptoms. And radiologists report lumbar disc herniation in 25% of normal population in adults. So our logo must always be that operate the patient, not the films. So I'm very surprised that many patients are sending email or WhatsApp messages to find a solution for their spine problems and sending one image or a report of the image, but they don't care about the examination or history taking. So we must be very skeptical for giving diagnosis to internet emails or WhatsApp messages. Besides, I am showing this example. This patient has came to me with a 3 months history, but when I saw that patient, he had almost no pain, and I did not recommend the surgery. Although there is a huge free fragment of disc herniation, L5S1 on the right side, caudally migrated, but what would be a surgery do? That there was no motor deficit, nothing. I didn't operate him. What is lacking in our training programs? We focus more on surgical techniques, not patient evaluation. Seniors do not make clinic or patient examination with juniors. Lack of knowledge, natural course of the disease, patient-based outcome measures. These are lacking. And what another thing, very important thing is how to take informed consent. We must tell surgery. I will give one example of sciatic pain. Natural course of sciatic pain is what we really don't know very well. It is from 1970, Hakelius has done a 7 years follow-up and comparison of two groups, surgical group and conservative group. Surgical group had more rapid improvement and return to work, but conservative group had slower improvement and return to work. However, both groups were same at the end of 7 years. And the recurrence of sciatic pain was same in both groups, 12%. One of the most cited paper is from Weber. It is 1983, almost 30 years. It was a randomized controlled study with 126 patients. And he was telling at the end of 4 years, there was no difference in success rates of surgical and conservative groups. However, at the end of 1 year, surgical group had 65% satisfactory results, conservative group has 24%. This is a study from 1992. Medical costs of surgery were high, but costs of conservative therapy because of work time losses were also high. So then they decided conservative therapy is more costly. So our informed consent must consist of those evidence-based spine surgery guidelines or information taken from the literature. What it must have, informed consent, what a patient must learn. One is the success rate of surgery. For this condition, you can say 90% success rate. Complication rate, you can say 9 to 10%. Major risks, probably 1% or 1 to 3%. Alternatives, yes, there are alternatives. And cost of surgery, it depends on the conditions, whether it is private or official or other. For the success rate, the outcomes tests, if they are physician-based evaluations, usually report better outcomes. You can read from the literature, 99% success rate, because the surgeon are declaring that, hey, you are right, you are bad, you are good to the patient. But if you ask the patients, they usually report worse outcomes. Their expectations are maybe somewhat different than what you think as a surgeon. So even for a disc herniation, it may be as low as 60%, 70%. Recommending surgery for lumbar disc herniation. The main reason is to decompress and relieve the pain. And if it's acute, it may resolve in the first 4 weeks. After 4 weeks, it will not get a very fast recovery. But in 1 year, it will probably be mostly relieved, the pain, I mean. But if you say that if not operated, you'll be paralytic, or you'll get impotence, then the patient will accept the surgery. This is not true, but this is one of the most common mistakes that's been done. A surgery, does it cause any vital problem? No. Does it cause any neurologic deficits? No. Pain can resolve by the time? Yes, it may. But are you able to, if the pain is so severe, are you able to wait for 1 month or 12 months? You must tell the patients. In conclusion, we must know the natural history of a disease. So I don't want to repeat this. Actually, these are what the patients must know from us. And for the recurrence of disc herniation is approximately 10 to 15%, but the back pain recurrence is quite high, 25%, maybe more. I actually say the disc herniation patients, this is to relieve your leg pain, not your back pain, I tell them. I will just finish my talk before saying something about the electrophysiology and spinal disorders. Actually, there are many reasons as physicians ask for electrophysiologic tests. These are to learn subclinical neurological affection. Is it possible? I don't know. I'm not sure for that. In case of multi-level radiological lesion, to learn which level is causing the neurologic symptoms and signs, probably you can learn in 20 or 30% of cases. This is just estimation. This is not a real scientific data. There is no good scientific data on that. For differential diagnosis of radiculopathy from peripheral neuropathy, it is not known well. Actually, I'm very curious about the differentiation is possible. To differentiate a spinal cord lesion from a nerve root lesion, probably in 10% it may be done. To evaluate if a neural injury is acute or chronic, and to learn if it is regenerating or not, probably 60 to 80%. For those reasons, I do not order any EMG or nerve conduction study in any lumbar disc herniation, cervical disc herniation, cervical myelopathy, and lumbar spine stenosis. But I order if there is a polyneuropathy possibility, if there is a possibility of ALS, if I am following up a foot drop, if there is a foot drop without pain because of estimation of fibular nerve compression, and in case of cauda equina syndrome, to follow up them well, I order EMG in those conditions. Critic, mostly from neurologists, come that surgeons cannot differentiate ALS, polyneuropathy from surgical disorders and operate them. They criticize us. To not be in those critics, we must consider polyneuropathy if there are glow-stalk type symmetrical sensory deficits, neuropathic pain more intense than somatic pain, pain during rest, and symmetrical deep tendon reflex losses. ALS considerations, if there is motor weakness without pain, muscle atrophies are more prominent, symmetrical weakness, and fasciculations. Order EMG and nerve conduction velocity study if there are symmetrical sensory deficits, neuropathic pain, pain during rest, symmetrical DTR losses, atrophy is more prominent, and if there are fasciculations. Sometimes EMG specialists cannot differentiate ALS from other diseases if he's not in the proper muscle. He must be inside the muscle that is fasciculating. So then he will see giant motor unit potentials, which are very abnormal and very specific for ALS disease. In conclusion, EMG and nerve conduction velocity high specificity in diagnosis of peripheral nerve lesions and entrapment neuropathies. But it has very low value in radicular lesions, worse than clinical evaluation. The comments and evaluation of electrophysiologists are more valuable. Why is it so? Because most of the time, the patient has just pain. There is no electrophysiological test to examine the pain level. There is no test at all. This is just a subjective feeling. A patient must define his type of pain. There is no test for pain evaluation. So if you look at the diagnostics, anamnesis has the biggest value. Then the examination, electrophysiology is lower value. Radiology has more value than electrophysiology, even than examination probably, but there is a risk of unnecessary diagnosis and diagnosis of incidental pathologies. So, spinal disorders are very often, however, most are non-specific, 85% non-specific. For mechanical low back and leg pain, diagnosis tests are rarely necessary. Conservative therapies, exercise recommendations are good enough. Learning the pain well is very important to differentiate. Operate the patient, not the films, must be our logo. Good training is very important and should be done in the hands of societies and academic centers. We must not forget the natural history of any disease, and alternatives for non-specific spinal pain must always be told to patients and seek those alternatives. We need more class 1 and 2 studies for evidence-based medicine. So this is my last slide. Patient evaluation is more important and more difficult than surgical techniques in spine. And unfortunately, during the COVID outbreak, we canceled Istanbul Spine Masters to October 1 to 3. I wish everything will settle down at the time and we will be able to make this meeting. And we also postponed the Milan meeting to 2021, March 2021. Thank you for listening to me.
Thank you, Dr. Zileli.
Sorry, Sandeep, carry on. You are the moderator.
Yes.
Hi, Sandeep. How are you?
Good. So I'm sorry I could not log on at the time. So I was just a couple of minutes late. But you said rightly, the sort of MRIs where the radiologists report the disc and the patients get unnecessarily worried that they have something and they come with an actually they are fine. On the other hand, a lot of, I mean, as you rightly said, that these patients are told that they will develop paralysis or impotence. So it is very important for us to tell the right thing to these patients. So now we will ask the questions. I think one of the questions was that if a patient has a disc prolapse and has got a less than 25% listed, so will you fuse that patient?
Less than 25%?
Subluxation, yeah.
Subluxation. Yes, actually, in this herniation patient, a fusion surgery may be necessary in certain conditions, not most of the time, very rarely. If there is significant back pain additionally for ongoing, continuing back pain, if there are instability signs like some subluxation or severe modic changes, if there is the disc height preservation, you can also consider a fusion surgery, right?
Would a dynamic X-ray decision? Suppose if on dynamic X-ray there is no movement.
Yeah. If there is no movement, if the disc height is very low, if there is no back pain, it's not necessary for surgery to make a fusion surgery.
So, any more questions? People are not writing their questions.
Okay.
There another question. Do you operate patient only for back pain and degenerative changes like mild to moderate canal stenosis?
No, mostly not. If there is a spine canal stenosis, there is no neurogenic claudication, just back pain. I first consider physical therapy or injections. Sometimes facet injections may be helpful, or epidural injections may be helpful. I wouldn't consider a fusion surgery with low back pain only in a lumbar spine stenosis patient. If there is, however, significant instability. If there is significant instability.
In a recurrent disc prolapse or a recurrent.
Oh, this is a good question. In recurrent disc herniation, if it is second recurrence, I always recommend a fusion surgery. If it is a first recurrence, and in this recurrence, if there is no back pain or in the history back pain episodes, I just do a simple discectomy. Yeah. But if there is severe back pain episodes, if there is modic changes, if there is some movement in flexion extension films, if the disc height is very high, so those patients may be a candidate for a fusion surgery.
So in those patients where you are fusing, would you do a percutaneous fusion or you would do an open fusion in a recurrent patient?
I do open surgery, but I'm not against percutaneous screw fixation. It may be done.
Mehmet, what I would say that, there are some patients in whom you do need proper decompression or there is scar or whatever, and then you may be better off doing an open surgery. On the other hand, majority of the time, you can get away with minimally invasive surgery these days, doing maybe an MIS TLIF kind of thing. That may be an option.
Okay.
Nicola, sorry, carry on. Mehmet, carry on.
Yeah, scar tissue may be a problem in open surgery and minimally invasive surgery, in both of them.
Yeah.
It doesn't matter.
So if it's a lot of scar, if you're coming from the joint itself, you're coming transforaminally, then obviously you don't hit the scar. And that's why it may be an option by doing an indirect decompression, by elevating the disc height as well. So that's an option.
Yeah. So unilateral pedicle screw fixation may also be an option in that instance.
Nicola, you are there. You want to ask any question or discussion?
Yes, I wanted to ask, with regards of multi-level degenerative spine, sometimes, for example, when I examine my patients and when I see the MRI scan and I'm still, and I'm talking to the patient, I'm still not aware where the pain generator is. I know some people don't accept this term pain generator, but I still use it. I think it's something that I can explain easy to my patients what is it about. So say symptomatic level, so it's probably more accepted. So when I'm not sure exactly which level is symptomatic, I normally do steroid injection. I wanted to ask what do you guys think about that and how this is in your practice? And then the second question, to make it a bit more modern and in line with the current situation of coronavirus. So we have received from nearly all the insurers that the steroid injections during this coronavirus outbreak should be stopped because steroid is decreasing the immunity of the patient. I had a few conversations with different anesthetists, and actually some of the societies later on said that this is not proved, and because we use locally and not very big dose of steroids, we cannot for sure say that this could be harmful for a patient with coronavirus. So what is your take on that, and what are your comments?
In fact, our pain physicians do not make any injections nowadays, and we also don't do it. But I don't think one dose of injection will be very much concern for COVID infection, because it's just one.
Yeah, that's my take as well, and that's what I wrote to the societies back, saying that this is a procedure that should not be banned. And I spoke with a few physicians, and they think the same. But we got letters from all the insurers to stop these injections. Of course, now we don't do much of these procedures, but maybe in the nearest future we'll resume, and we should know what to do with these patients. But do you do otherwise injections to discriminate the level in your practice, Mehmet? What is your practice with that, if you have multi-level?
I'm sorry, Nikolai, we are running out of time. You have only 30 seconds left. So maybe we will discuss this when we come back for a session day after tomorrow. And maybe we can start with this discussion first.